thank you for joining our webinar, Matching a Patient's Unique Tumor Profile with a Safe and Effective Therapeutic Combination. I'm Laura Towart. I'm the founder and CEO of Vivan Therapeutics, and I'm joined today by Dr. Nahuel Villegas, Chief Scientific Officer, and Dr. Dan Krell, Consultant Medical Oncologist from HCA London and the Royal Free Hospital.
Hello, everyone. Thanks for the intro, Laura. And yeah, so what I'm going to do in the next 15 minutes or so is talking about how we use patients' tumor profiles to identify very personalized treatment recommendation for our patients. I'm going to start with a very general statement, just saying that cancer is not a single disease. This is something that's very well known now, but we are talking about thousands of different diseases. And one of the main features that makes, I hope the slides are okay there. So one of the main features that makes every tumor to be different, to be not really unique, but kind of unique, is the genetic makeup behind each of these tumors. When you dissect a tumor, when you analyze a tumor from the molecular point of view, what you're going to find is in average 4 to 5, it could be more, could be less, but in average 4 to 5 different genetic alterations, talking about oncogenes and tumor suppressor genes in general. And what you see in different tumors, even though when we are talking about the same tumor profile, the same tumor type, sorry, what you see is that behind every tumor, you are going to see a different type of genes, different type of alterations, either a different set of genes or a different configuration of these genes. So the question is, how do we use this information coming from molecular profiles to identify new treatments that are tailored, that more personalized for every person? So here is a molecular profile that extracted from Foundation One. This is one of the typical profiles that you can see. Probably Foundation is one of the most used profiles now. You have many others from Garden, from Tempus, and Boston Gene, other providers. They are all pretty good, to be honest. The question is what you do with that information. And the information that you get here is a list of genes, a list of genetic alterations. And each one of these genetic alterations, well, not all of them, but some of them match with some suggested treatments in terms of drugs. So for instance, for the top alteration here, let's see if you can see my laser. You have 4 different drugs that you can use, MEK inhibitors. And then for the second one, that it happens to be a MET amplification, you have 3 different drugs. And then for the other one, 3 other masks, 3 other ones, and so on. And then the question is, if you are the physician, if you're the oncologist, which of these drugs or drug combinations are going to use for your patient? You cannot use them all, of course, because it could be very toxic. And you don't know exactly which combination you are going to use that might be or not might be more or less efficient. And on top of that, you have here a number of alterations which are not linked to any drug, any treatment. These are the so-called non-actionable genetic alterations. And what you are missing here is the full picture. And a full tumor is not just the sum of these genetic alterations in an individual way. A tumor is all these genetic alterations working together, contributing together to tumor initiation, to tumor growth, and to resistance to therapies. And this is what we use to generate our models that I'm going to explain in a minute and to develop our therapies. So, but before that, I'm going to just take a tour into other traditional preclinical models that people are using now to develop novel treatments. So there are a number of approaches, basically in vitro approaches and in vivo approaches. In terms of in vitro approaches, what you can do is to isolate the cancer cells from the tumor of the patient. You can grow them in a dish, and then you can expand them, and then you can try different drugs until you find out which one are working better. So you have the 2-dimensional cultures, the 2D ones, which are a big advantage of this is that you can create a really high number of these cancer cells. We're talking about hundreds of thousands of this one, maybe millions of them. So you have a really good number to test a good number of drugs. So this is basically a high throughput approach. The problem with this is not reliable at all. The data that you get is very unreal. It's not really that hard to kill a cancer cell in a dish, but these therapies don't really translate to humans when you try them in clinical trials. And of course, there are other issues about the proper practice. It's difficult to have in your hospital all the know-how, all the instruments that you need to create this type of models. So the other ones, the 3D organoids in different shapes and ways, is really an improvement of the 2D cultures, because now you can create some sort of 3D structure in the dish, but it's still an in vitro system, so quite artificial way to obtain information. And on top of that, it's much more expensive, and the throughput is much limited because you cannot create many of these organoids for every patient. And then you have the in vivo approaches. Basically, you use these cells here, you inject them in mice or other animals. Mice is the golden standard. So now you have a tumor growing inside a proper animal. So it's more similar to what you see in humans and in patients. The problem here is that the throughput is very limited. So you are able only to test a handful of treatments, usually the 3, 4, or 5 different standard of care treatments that are available for your patient. But you cannot use this to discover novel and better therapies for the patients, or personalized therapies for the patients. And lastly, you have some in silico approaches as well. Basically, you try to make sense of the data in the databases, try to match a tumor profile with some therapies. But the problem here is that data, at least in oncology, in medical oncology, is really poor, and is heavily populated with treatments that they are not really working, and they are not clearly matched to tumor profiles. So you cannot really use these computational approaches to recommend anything for your patients. So what we do, I'm going to explain the personal discovery process, and this is how we use tumor molecular profile from our patients. We start with the tumor profile, and we can get this. We can do the sequencing, or we can get information from other companies, as I just mentioned, Foundation One, Guardant, Tempus, etc., etc. And the next step is really the one that makes that place or set this technology apart from other ones, which is whatever we identify in the tumor of a patient, we use quite sophisticated genetic tools to engineer these alterations in fruit flies, very humble, very tiny, and very simple fruit flies. What happens next is that we activate these alterations, and that tiny fruit fly is going to develop the same tumor as the patient, not any tumor, the same one from the genetic point of view, the same tumor as a patient. So we call it an avatar of the patient. And why we use fruit fly? For a number of reasons. And one of them is it's the only animal that you can engineer all these many genetic alterations, up to 20 different genetic alterations. We can engineer, and we can activate them in the tissue that we want at the moment that we want, in whatever ways and means we want. You cannot do this with any other animal model. And another extra advantage, very important, they proliferate very fast, and they're very tiny and very easy to handle. So in a relatively short period of time, we create hundreds of thousands of them for every patient. Usually, we would create 500,000 for every patient. Each one of these animals with the same tumor as the patient. And having the chance to deal with this massive number of animals with tumors, we do a high throughput drug screening. We test from 100 to thousands and thousands of drug combinations until we find what is the best, most optimal treatment. Actually, it's a list of treatment that we recommend to the patient and the oncologist. So basically, we can put together in one single model all the advantages of the in vitro system, which is the high throughput, and all the advantages of an in vivo model, as we are working with an animal as well. So And we have some clinical studies performed at Mount Sinai Medical Center. And actually, the technology was developed at Mount Sinai in New York, and we are partners on this. And this is the case of a patient with colorectal cancer who have failed every single line of treatment, all standard of care treatments, no one of them working in the patient. A sample of a tumor was taken, analyzed, and 9 different, this one that you can see here, 9 different alterations were identified in that tumor and were engineered into a fruit fly. So a fruit fly was built with this information, and a drug screening, an in vivo high-throughput drug screening was performed with this, using these avatars. And thanks to that, a novel treatment was identified. The patient took this treatment and happened to be the only one that actually works in the patient. In this case, it's already published. There are other cases as well. This one, the first one is a colorectal cancer. I don't know if I mentioned already or not, but we are heavily working with GI cancer, gastrointestinal cancer. So that is one of the top tumors we are dealing with right now. But we can model other solid tumors like this other patient with a salivary gland tumor, also from Mount Sinai Medical Center. So by now, we have been doing this for a number of years now. We have been able to screen more than 50 million animals so far, and the data keeps increasing every day. And we have been able to identify more than 500 novel therapies for the patients, actually now reaching 600 novel therapies, all of them, or most of them actually, outperforming the standard of care. And the relevance of this is that with all this massive data that we are generating from our in vivo models, we are now using it to feed a software that we call it TuMatch. TuMatch is basically a software as a medical device that can very rapidly, very quickly match a molecular profile from a patient. We just need to know which are the genetic alterations in that tumor, and then we match it to our database, which is really big right now, and we can provide a very fast and very quick treatment recommendation for our patients. As you can imagine, the previous approach, when we have to build all these animals, takes some time, of course. But with the TuMatch software, we can provide a very quick recommendation. And what we recommend, this is just to show you one example of a treatment report that we provide to the oncologist and to the patient. This is a KRAS-driven colorectal tumor. And in the report, you have basically 3 categories or 3 flavors. The standard of care therapies that we test alongside everything that we have identified new. Then you have a second category that involves treatments in different clinical stages, right now in different clinical trials that you can send your patient there. And novel treatments, which are usually more effective than the other ones. But I'm going to stop here. I'm going to pass the torch to Dr. Krell, who's going to elaborate a bit further about the treatments that we are generating and recommending.
Thanks, Nahuel. So yeah, so as you said, the top panel there is of standard of care therapies, which depending on when the testing is being done, may be therapies that patients haven't had. So I think that's helpful to give an indication of which of the standard of care therapies may be more effective as first or second line treatments. More likely, patients may have been through several lines of therapy before the testing's done. And then that leads into the other options here. So the middle panel is treatments in the clinical stage. So treatments that have been tested in cancers, either different types of cancers or the same types of cancers, or may be available in clinical trials. So that can be helpful in identifying options, particularly if there are clinical trials using those therapies. And then the third group is novel treatments, so treatments that may not have been tested as extensively, and also some repurposed drugs, which are becoming more popular with patients, perhaps with less evidence, but this may give some rationale for combinations of of chemotherapy or anti-cancer therapies and repurposed drugs in combination. So that's really what the reports give us as a clinician.
Thank you, Dan. I'm going to pass to you, Laura.
Thank you. Thanks, Nahuel. So one case really illustrates the power of our platform quite well. So this is a case where we were able to identify treatment for a patient with a very rare salivary gland cancer in which there were no standard of care options. And so we were able to provide patients and their families with hope and options even when it seems like it's not possible. Explain a little bit about how to contact us and to see if we're able to offer a therapy for the type of cancer that you're interested in. So on our website, you can actually either click Start Now, and then you're brought to a point where you can upload a molecular profile. So the starting point for working with us is really having us analyze whatever has already been done in terms of molecular testing. And so if more than one genetic alteration has been identified already, then usually that's enough for us to have an idea of whether we need to create an avatar or if we have a personalized recommendation via the software product. And we're always happy to speak with patients and oncologists. Our consultations are free, and you'd be speaking directly with Nahuel or I. So you could book a consultation directly there. As Nahuel mentioned, so we're able to work with patients. Our main focus is gastrointestinal cancers, but we could also work with patients that have glioblastoma, lung cancer, many other cancer types. We try to stay away from any cancers that are hormonally driven.